We discussed at the meeting approaches of implementing CAR-T on the inpatient side and then subsequently transitioning to the outpatient side. And I think some of the things that were stressed in terms of choosing a product and a patient to administer CAR-T safely on the outpatient side include reliable patient, minimum comorbidities, people that have caregiver available 24/7, and then folks that have a limited amount of tumor burden such that you don't expect them to have very severe toxicities in a very soon period after their CAR infusion. After the patient, you're looking at the product. So what are product-specific criteria for outpatient administration? I think it's predictable toxicities. It's toxicities that gradually have an onset. And again, safe administration of the outpatient setting is really paramount for having reliable time to toxicities and being able to anticipate and teach patients about when to experience those. And then when you're looking at on the institutional approach, how you can do this safely outpatient, I think you have to look at staff training. You have to look at the availability of beds at 24/7 if a patient does subsequently need inpatient admission. There has to be a seamless inpatient to outpatient transition such that the care teams are constantly communicating and that patient can get into the hospital in a reasonable time frame and be managed appropriately. We talked about tocilizumab administration and how you would administer that, likely for following inpatient administration. At our institution, we don't store tocilizumab in the outpatient setting. We keep it inpatient because the patients are typically admitted with higher than grade 1 CRS. They're presenting with fever, and then we're subsequently managing more severe sequelae after inpatient admission. So there's a lot of logistics about using CAR-T in the outpatient setting safely. It can be done. We talked a bit about data supporting outpatient administration of CAR-T with the 3 agents that are approved for large cell lymphoma, so that being Axicabtagene, Lisocabtagene, and then Tisagenlecleucel. Most of the outpatient experience at this point is with Tisagenlecleucel. About a quarter of the patients in the Juliet trial were treated outpatient with that agent, and at our institution at University of Pennsylvania, we typically administer Tisagenlecleucel outpatient as our default setting, and we generally have criteria that the patient has to meet in order to somewhat buy inpatient admission, that being poorer performance status, comorbidities, large amounts of tumor burden, maybe lack of a reliable caregiver, those types of things. So, and in our experience thus far, 1/3 of the patients end up needing admission to the hospital with a median time of admission of 5 days. That means that 2/3 of these patients stay outpatient and never need admission within the first 30 or even 60 days after their CAR infusion. So it highlights the tolerability of Tisagenlecleucel for outpatient administration. There's some experience in abstract form looking at outpatient Lisocabtagene as well across a few studies, and it seems that a bit higher amounts of those patients are admitted, about 60% or so, again around the median time of about 5 days after administration of CAR-T therapy. But again, that means that about 1/3 of these patients don't need hospitalization within the first month. And within the trials for liso-cel, you saw that there were similar amounts of use of ICU transfer of things like hemodialysis and oxygenation and pressors. There doesn't appear to be a clinical detriment of treating those patients outpatient. You can administer it safely in the outpatient setting. There's a trial that even showed that lower amounts of tocilizumab were used in patients that were treated outpatient, which is an interesting finding. So again, these two 4-1BB stimulated products, Lisocabtagene and Tisagenlecleucel, seem to be safe for outpatient administration. The question really remains about Axicabtagene and if you can safely administer that outpatient. And to my knowledge, I'm aware of one abstract that came out of the Mayo Clinic, Rochester, that looked at a home-based outpatient program that was quite comprehensive in terms of vital sign monitoring and monitoring of neurologic symptoms. And they treated a small number of patients outpatient. Most of them still needed hospitalization, many within the first 2 days following administration of the CAR product. So I think there remains a bit of a barrier for safe administration of Axicabtagene outpatient, but I think with further experience, we may be able to transition some of those patients outpatient.